Here's something that I think is one of the most profound injustices in modern medicine. Half the population goes through a biological process so complex, so physiologically significant, that it touches virtually every organ system in the body, the brain, the heart, the bones, the immune system, the gut, and yet for decades, the medical establishment either dismissed it, misunderstood it, or worse, actively scared women away from the one intervention that could meaningfully improve their health and quality of life. I'm talking about the hormonal life cycle of women: menstruation, perimenopause, menopause, and hormone replacement therapy. And today, I want to go deep on all of it, not in a fluffy surface level way, but the way I wish every woman's physician would sit down and actually explain it to her. Because here's what I've come to believe after years of thinking about longevity and health span. Menopause is not just a reproductive event. It is a metabolic, cardiovascular, neurological, and skeletal event. And the way we handle, or mishandle, the transition through it has enormous consequences for how women age. So let's start from the very beginning. The female reproductive system is governed by a hormonal axis that is, frankly, a masterpiece of biological engineering. You've got the hypothalamus at the top, sitting in the brain, sending signals down to the pituitary gland, which then communicates with the ovaries. This is called the hypothalamic pituitary gonadal axis, or the HPG axis, and it's the conductor of the entire hormonal orchestra. The two primary players in this orchestra are estrogen and progesterone, though testosterone also plays a critically underappreciated role in women, something we'll come back to. From the time a girl enters puberty, usually somewhere between age 8 and 13, this axis activates and begins driving the menstrual cycle. The menstrual cycle is not just about reproduction. I want to be really clear about that. It is a monthly report card on a woman's overall health. When the cycle is regular, predictable, and relatively symptom-free, that's a signal that the hormonal axis is functioning properly. When it's irregular, painful, or accompanied by significant mood disturbances, that's the body waving a flag. A typical menstrual cycle runs about 28 days, though anywhere from 21 to 35 days is considered within the normal range. The first day of bleeding is day 1. This is when estrogen and progesterone are both at their lowest. As the cycle progresses into what we call the follicular phase, roughly the first 2 weeks, estrogen begins to rise. It's being produced primarily by the developing follicles in the ovaries. And as estrogen rises, something interesting happens across the entire body. Mood tends to improve. Cognitive function, particularly verbal memory and processing speed, often sharpens. Insulin sensitivity improves. Energy levels tend to climb. The lining of the uterus thickens in preparation for potential pregnancy. And then, around the middle of the cycle, you get a sharp spike in luteinizing hormone, which triggers ovulation, the release of an egg from one of those follicles. After ovulation, the follicle that released the egg transforms into something called the corpus luteum, and this structure begins secreting progesterone. Now you're in the luteal phase, the second half of the cycle. Progesterone has a very different character than estrogen. It's calming, sedating in some ways, and it plays an important role in sleep and mood regulation. But for women who are sensitive to progesterone's effects, or for whom the ratio of progesterone to estrogen becomes imbalanced, this second half of the cycle can bring irritability, bloating, breast tenderness, low mood, and disrupted sleep. If fertilization doesn't occur, both estrogen and progesterone drop sharply, the uterine lining sheds, that's the period, and the cycle begins again. Now, What often doesn't get enough attention in these conversations is the variability of this experience across women. Some women move through their cycles with minimal symptoms and relatively little disruption to daily life. Others deal with dysmenorrhea, which is painful menstruation, severe enough to be debilitating. Some have endometriosis, a condition where tissue similar to the uterine lining grows outside the uterus, causing chronic pain, inflammation, and in many cases, significant fertility challenges. Some have polycystic ovary syndrome, or PCOS, which is one of the most common hormonal disorders in women of reproductive age and involves irregular cycles, elevated androgens, and metabolic dysfunction. The point I'm making is that the menstrual cycle is an incredibly rich source of clinical information, and we should be paying much closer attention to it than we typically do. Now let's fast forward to what happens as women move toward the end of their reproductive years. This is where things get really important from a longevity standpoint. The transition to menopause is called perimenopause, and it is, without question, one of the most misunderstood and underserved phases of a woman's life. Perimenopause typically begins in a woman's mid to late 40s, though it can start earlier, sometimes in the early 40s. It can last anywhere from a few years to more than a decade. Let that sink in. A decade. And during that entire period, a woman may be experiencing significant hormonal fluctuations with very little guidance or support from her medical team. Here's what's actually happening physiologically. The ovaries begin to run out of follicles. Remember, women are born with all the eggs they'll ever have, somewhere between 1 and 2 million at birth, down to about 300,000 by puberty, and continuing to decline throughout the reproductive years. As the ovarian reserve diminishes, the follicles that remain become less responsive to the hormonal signals coming from the pituitary. The pituitary responds by shouting louder, pumping out more follicle, stimulating hormone, or FSH, in an attempt to recruit follicles. This is why elevated FSH is one of the blood markers we use to assess where a woman is in the menopausal transition. But the follicles aren't as responsive, and the result is increasingly erratic estrogen production. And I mean erratic. Estrogen levels during perimenopause can swing wildly from very high to very low within the same month. Sometimes within the same week. These estrogen fluctuations drive many of the classic perimenopausal symptoms. Hot flashes and night sweats, which are collectively called vasomotor symptoms, are experienced by roughly 75% of women during this transition. The mechanism involves estrogen's influence on the thermoregulatory center in the hypothalamus. When estrogen drops suddenly, the thermostat gets destabilized, and the body misinterprets its own temperature, triggering a heat dissipation response. Sweating, flushing, that wave of heat that can wake a woman up 5 times a night. Sleep disruption, as you can imagine, has cascading effects on mood, cognition, metabolic health, and cardiovascular risk. But here's what I want to emphasize, because I don't think this gets nearly enough attention. The symptoms of perimenopause and menopause are not just quality of life annoyances. They are surface-level manifestations of deeper physiological changes that have real implications for long-term health. Let me walk you through some of the most important ones. Bone health first. Estrogen is one of the primary regulators of bone remodeling. It inhibits the activity of osteoclasts, the cells that break down bone, and supports the activity of osteoblasts, the cells that build bone. Throughout a woman's reproductive years, estrogen helps maintain bone mineral density. But in the years following menopause, when estrogen levels fall dramatically and stay low, bone breakdown accelerates sharply. Women can lose between 10 and 20% of their bone density in the 5 to 7 years following menopause. That's an enormous amount. And the downstream consequence is a dramatically elevated risk of osteoporosis and fragility fractures, hip fractures in particular, which carry a 1-year mortality rate of around 20% in older women. This is not a trivial issue. Cardiovascular health second. This one is deeply underappreciated. Before menopause, women have significantly lower rates of cardiovascular disease than men of the same age. After menopause, that protection evaporates, and women's cardiovascular risk rises steeply, ultimately catching up to, and in some measures surpassing that of men. Estrogen has multiple cardioprotective effects. It improves the lipid profile, tending to raise HDL and lower LDL. It has anti-inflammatory properties. It supports endothelial function, the health of the inner lining of blood vessels. It influences how the body handles glucose and insulin. When estrogen falls, all of these protective mechanisms weaken, and women become far more vulnerable to atherosclerosis, hypertension, and ultimately heart attack and stroke. Brain health third. This is the one that I find perhaps most fascinating and most concerning. The brain is loaded with estrogen receptors, particularly in regions critical for memory, mood, and cognitive function. The hippocampus, the prefrontal cortex, the amygdala. Estrogen supports neuronal survival, synaptic plasticity, and the production of neurotransmitters, including serotonin, dopamine, and acetylcholine. When estrogen levels decline in menopause, many women experience what they describe as brain fog, difficulty concentrating, word-finding problems, memory lapses. These symptoms are real, and they are neurobiological in origin, not psychological. There is also a growing body of evidence suggesting that the menopausal transition may be a vulnerable window for the brain in terms of Alzheimer's disease risk, and that the timing of hormonal support during this window may matter enormously. Which brings me to the most important and most contested topic in this entire conversation: hormone replacement therapy, or more accurately and more modernly, menopausal hormone therapy, or MHT. To understand why this topic is so fraught, you need to understand what happened in 2002. The Women's Health Initiative, one of the largest randomized controlled trials ever conducted in women's health, published its initial findings and essentially ignited a panic. The study was looking at the use of combined estrogen plus progestin therapy in postmenopausal women, and when the Data Safety Monitoring Board stopped the trial early, the headline that went out to the world was that hormone therapy increased the risk of breast cancer, heart disease, stroke, and blood clots. Prescriptions for hormone therapy plummeted virtually overnight. An entire generation of women was scared away from treatment, and an entire generation of physicians became reluctant to prescribe it. Here's the problem. The Women's Health Initiative findings were real, but deeply misinterpreted and overgeneralized. And the consequences of that misinterpretation have been, in my view, a public health catastrophe. Let me explain why. First, the population studied in WHI was not representative of the women most likely to benefit from hormone therapy. The average age of participants was 63. Many of them were a decade or more past menopause. They were not the recently menopausal women. The 48 or 52-year-olds in the thick of perimenopausal symptoms, who are the primary candidates for hormone therapy. When you start hormones in women who are already significantly past menopause, particularly those who already have subclinical cardiovascular disease, you may be doing more harm than good. This is what's now called the timing hypothesis or the window of opportunity hypothesis, and it has substantial and growing support in the literature. Second, the type of hormones used in the WHI matter enormously. The estrogen used was conjugated equine estrogen, estrogen derived from pregnant horse urine. The progestin used was medroxyprogesterone acetate, a synthetic progestogen that is not bioidentical to the progesterone naturally produced by the human body. Modern hormone therapy can use estradiol, the primary estrogen produced by the ovaries, delivered transdermally through a patch or gel, along with micronized progesterone, which is bioidentical and has a very different safety and tolerability profile. These are not the same hormones used in the WHI, and the risks are not the same. Third, the absolute risks found in the WHI were actually quite small, even in that older population. The relative risk numbers sounded alarming, but when you translated them into absolute terms, actual additional cases per 10,000 women per year, the numbers were much more modest. And for many of those same women, the risks of not treating accelerated bone loss, cardiovascular disease, cognitive decline were arguably higher than the risks of treating. So, what does the modern evidence actually say about hormone therapy for women who are in perimenopause or recently postmenopausal? The picture is, in my reading of the literature, largely reassuring and in many domains actively positive. Let me go through this carefully. On hot flashes and night sweats, hormone therapy is simply the most effective treatment available. Nothing else comes close. SSRIs and other non-hormonal options have modest effects. Hormone therapy has large effects. For women with severe vasomotor symptoms that are disrupting sleep and quality of life, this is not a trivial benefit. On bone health, estrogen therapy has robust evidence for preserving bone mineral density and reducing fracture risk. This is one of the clearest and most consistent findings in the field. The beneficial effect on bone is dose-dependent and requires continued use. The benefit diminishes when therapy is stopped. But the data here are genuinely strong. On cardiovascular health, the picture is nuanced but important. The timing hypothesis has strong support. When hormone therapy is initiated in women under 60 or within 10 years of menopause onset, multiple observational studies and the reanalysis of WHI data suggest a reduction, not an increase, in cardiovascular events. The cardioprotective effects of estrogen appear to be most relevant when the vasculature is still relatively healthy. Once significant atherosclerosis has developed, which is more likely in women who are already a decade or more past menopause, the situation may be different. This is why the timing of initiation matters so much. On brain health and cognition, this is an area of intense, ongoing research. The observational data are largely consistent in showing that women who use hormone therapy during the menopausal transition have lower rates of dementia and better cognitive function in later life compared to those who don't. The WHIMS study, the cognitive substudy of the WHI, found increased dementia risk with conjugated equine estrogen plus medroxyprogesterone in women over 65. But again, this was an older population using older hormone formulations. The Cache County study and several other large observational studies have found the opposite pattern in appropriately timed users. We don't have a definitive randomized trial answering this question for younger, recently menopausal women. The COG-I-2-ION trial and other efforts are attempting to address this, but the biological rationale for estrogen's neuroprotective role is strong, and the observational data are encouraging. On breast cancer, which is the fear that drove so much of the post-BUHI avoidance, the picture is more complicated and requires honest discussion. The combination of synthetic progestin with estrogen does appear to confer a small increase in breast cancer risk with prolonged use. This was a real finding in the WHI, though the magnitude was modest and comparable to the risk conferred by other lifestyle factors like alcohol consumption or obesity. Importantly, estrogen-only therapy used in women who have had a hysterectomy and therefore don't need progesterone to protect the uterine lining actually showed a reduction in breast cancer risk in the WHA estrogen-only arm. And there is growing evidence that micronized progesterone, the bioidentical form, has a more favorable breast cancer risk profile than synthetic progestins, though longer-term data are still accumulating. This is an area where the conversation with your physician matters, where individual risk factors need to be weighed, and where the old blanket statements about hormone therapy causing breast cancer are simply not accurate or complete. I also want to spend a moment on testosterone in women because this is almost entirely absent from mainstream conversations and yet clinically very significant. Women produce testosterone in the ovaries and adrenal glands throughout their reproductive lives, and testosterone plays important roles in women's libido, energy, muscle maintenance, bone health, and mood. Testosterone levels decline with age in women, and the decline accelerates around menopause. Many women in perimenopause and postmenopause experience low libido, reduced energy, and difficulty maintaining muscle mass, symptoms that may be at least partly attributable to low testosterone rather than, or in addition to, low estrogen. Testosterone therapy in women, typically at much lower doses than used in men, can meaningfully address these symptoms. It is not FDA approved specifically for women in the United States, largely because the pharmaceutical industry has not pursued that approval pathway, but it is used off-label, and the evidence base for its safety and efficacy in women is growing. This is an underutilized option that I think deserves far more attention. Now, a word about who should and shouldn't consider hormone therapy, because I don't want to leave the impression that it's right for everyone. Women with a history of hormone receptor positive breast cancer, or certain thromboembolic conditions, or active liver disease have contraindications that need to be carefully evaluated. Women with a personal or strong family history of breast cancer need individualized counseling and shared decision-making with a physician who is truly up to date on the evidence. This is not one-size-fits-all medicine, but the knee-jerk refusal to discuss hormone therapy, or the blanket statements that it's too risky that became so common after 2002, those are not evidence-based positions. They are the residue of a fear response to data that was more complex than the headlines suggested. What I'd encourage every woman to do is approach this topic with the same rigor you'd apply to any other important medical decision. Understand your symptoms. Understand your risk factors for cardiovascular disease, osteoporosis, breast cancer. Understand the formulations and routes of delivery, because transdermal estradiol, for example, has a much lower risk of blood clots than oral estrogen because it bypasses first-pass liver metabolism. Ask your physician specific questions. And if your physician dismisses the conversation or gives you outdated guidance, find a physician who is current on the evidence. There's also a broader point I want to make as we near the end of this conversation, and it's about the cultural framing of menopause. For too long, menopause has been framed as a natural process that women should simply endure. It's natural is not a medical argument. Plenty of natural things are harmful, and plenty of medical interventions improve on nature in important ways. Menopause is natural. So is dying of an infection before antibiotics. so is going blind from a cataract. The question is never whether something is natural. The question is whether we can reduce suffering and improve health outcomes in a safe and evidence-based way. And the answer for many menopausal women is yes, we can. The women who go through this transition deserve to have these conversations with their doctors. They deserve to have their symptoms taken seriously. They deserve to understand what's happening in their bodies at a mechanistic level, not just be handed a pamphlet about hot flashes. And they deserve to make informed decisions about hormone therapy based on accurate, current, individualized information, not based on the misinterpretation of a study from 2002 that has been substantially walked back and contextualized in the 20+ years since. If you take one thing away from everything I've said today, let it be this: menopause is not just about reproductive function ending. It is a whole body transition with real implications for your long-term health, and it deserves to be treated with the same medical seriousness we bring to cardiovascular risk management, metabolic health, or cancer prevention. The hormones that governed your physiology for 30 or more years don't just affect your fertility, they protect your bones, your heart, your brain, and your metabolic function. When they fall away, that protection falls away too. And we have tools, good tools, increasingly well understood tools to help bridge that gap. The goal of all of this, of every conversation I have, every piece of content I put out, is the same: to help you live not just longer, but better, more functionally, more vigorously, with more cognitive clarity and physical capacity for as many decades as possible. For women navigating the hormonal transitions of midlife, that goal is not served by fear or by silence. It's served by understanding, by data, and by honest, individualized medicine. So please, if you're in your 40s or 50s, or if you care about someone who is, take this seriously. Have the conversation. Read the literature or find people who have. Don't let the decisions that shape the next 30 years of your health be made by default or by outdated information. You deserve better than that. And the science, when you actually look at it carefully, gives real reasons for optimism. Thanks for watching. If you found this valuable, share it with someone who needs it. And as always, the goal is to help you live better, not just longer.